All right, so we can get started with today's meeting about now. Good morning, y'all. Hope you guys are doing well, and welcome to today's PHPA meeting. Hope you guys are all doing well, and yeah. Friendly Zoom reminders, just use your first and last name for attendance purposes. Always keep yourself muted, and if you have questions today, feel free to type it in the chat. And if I recall correctly, today is going to be a little bit more of a Q&A day, so feel free to send questions into the chat.
For a remind text, you can text 81010 and message SMC PHA to receive texts and reminders for messages and events.
Hi everyone. Quick reminder that we do have a link tree that you guys could always check out where we have our Discord website, our Instagram, our Facebook, and you could just click there. We always have links updated in there as well. So if you ever need the Zoom link or any other like forms, it will always be updated with our most current links.
Hello, everyone. So my name is Alyssa, and I want to say welcome to our Student Spotlight. As part of this association, we value the experiences and achievements of all of our members and want to take the time to highlight any goals, participation in internships or other organizations, or challenges you've overcome. So keep an eye out for the PHPA Student Spotlight form in your emails for a chance to be featured in our upcoming meeting. Spotlight students will be notified when chosen and will be announced in our weekly emails, Instagram, and our website.
Hello everyone. So quick, I'm pretty sure you guys know this is our last meeting, and I'm I'm like excited and nervous to bring in my Mary. She's my boss. But at the same time, I've been wanting to bring her on for like a very long time now. She's a registered dietitian, also like assistant director at Kaiser. But I'll pass it on to her so she could give you a more in-depth introduction.
Hi guys. So hi, I guess my name is Mary, and I am Jonathan's boss here at Kaiser. And since this is my first time really chatting with a club, I really didn't make slides because I needed to learn a little bit more about what you guys needed. So I wanted to just do more of like more conversational type things. I think to start out, I kind of want to know who wants to do what, who's going where. We got PAs, we've got dietitians, tell me about you guys so that I can talk about things they're going to be meaningful to you. Or even Jonathan, you can just tell me if everybody doesn't want to speak up, just like give me a little rundown on your group a little bit.
Yeah, I think for most of us, I think I can speak for everybody that most of us are probably nursing majors. I do know like a few members in our board are nursing. We may have some like PTs over here, some PAs that want to become future or pre-med even.
Okay.
But yeah, I would say mostly from what I've seen is nursing majors. I don't know if anybody else has a specific major that they want to see what's the correlation between nutrition and their major.
All right, no, that's good. Okay, so that helps. Okay, nursing majors, yay! Love nurses. Okay, all right. So I guess I'll just talk about myself just for a second because I think I'm pretty boring. So I'm not going to talk about it too long. But so I'm the assistant department administrator at Kaiser Permanente, West Los Angeles. I do currently I do a lot of local stuff. So I do patient services and also the clinical side. That's how it's structured here at Kaiser. Although I'm super clinical, and the food service stuff is not my love, but I can do it, so I do a lot of regional projects. That have been really exciting and give me a lot of job satisfaction. I think one of the things that I can say that I love about Kaiser is that if you've got something to bring to the table, they'll listen. And that's been great. My background is I and actually, when I was your age, I wasn't as focused as you guys were. I had an undergraduate degree in psychology, and then went into nutrition as a graduate student. So I went to NYU for my nutrition work, and I did my internship, my work at the Albert Einstein College of Medicine at the Bronx. I worked at big hospitals and little hospitals. So I worked in New York at New York Methodist Hospital in Brooklyn. I've worked at Cedars. I've worked at Scripps, worked at Kaiser. So I worked at the big hospitals, the big pedigree hospitals, but I also worked at smaller for-profit hospitals, maybe like Kindred and things like that. I would say to you that getting that perspective, so don't it's so easy to just want to work at the fancy hospital and everything like that. And that's great. But if you only work at one place in your career, you're going to lose nuance. And one of the things that I bring to the organization is that I've worked at so many places. So I see the post-acute care syndrome patients, yes, we're saving them in the ICU. And then we're sending them to a lower level of care, and they're deteriorating at a lower level of care. I have this great this perspective. I think that's one of the things that I really bring to the organization. That's a little different than a lot of other people. Yay. Oh, okay. Volunteer in Sunset. Yay. Okay, perfect. Yeah, I don't know if Sunset takes students. I'm not sure. But anyway, West LA does. Although I think Jonathan's going to be lined up in there. Anyway, so okay, so yeah, so that's one of the things that I would highly suggest. And I would say I'm a big malnutrition person. Big. The field of nutrition, so I'm going to move into the field of nutrition. It's changing a lot. So a lot of times people have a preconceived notion about what the dietitians are doing, and what they're doing is nuanced. It's different. There are dietitians so the field is really, really broad. So there are folks that work in food service, and they just, they manage the kitchen, and how many calories are in the chicken, and how much protein is in the chicken, and is it regulatory compliant? And the food service side is very regulatory oriented. It's very rules. It's very, safety, make sure the patients don't get sick. There's a lot of laws, Title 22, you can't, people have to be fed within 14 hours after their last meal. There's a lot of things that if you don't take the health department comes in on a regular basis. If you don't take care of that, you can bring the regulatory people right in. They can shut the whole hospital down. So the food service people have a lot of responsibility. Then there's the clinical side. So the clinical side is where my heart is. And you learn about that in your internship. You can work with, cardiac patients, you can work all kinds of things, but then ICU, whatever, but even the clinical side splits off. So you have the inpatient dietitians, and then you have the outpatient dietitians. The outpatient dietitians are a lot of, it's more like lifestyle medicine, putting you on the, diabetic educations, a lot of plant-based diet stuff, but that's kind of outpatient list. Inpatient is more about the isms. It's like metabolism. It's about when people are anabolic, when they're catabolic, taking advantage of anabolic potential. Don't push people when they're catabolic, trying to get them to not get wounds. It's like keeping people out of the sand trap, right? So it's a different job. They take different levels they both take a lot of study, and there's a lot of depth. And if you really want to be good at what you do as a dietitian, you just find your thing and you go deep, right? And whether it's inpatient or outpatient, people think that the inpatient dietitians are the food police. We are actually the please eat police. And our field is changing, and it's moving really rapidly, and malnutrition is becoming a huge thing. There's going to be a new CMS metric coming out about malnutrition in 2024. It's an optional one, but it's showing you that the medical field is starting to go, hey, wait a minute, these guys know what they're talking about. They've got something here. And so dietitians are rising. We are underutilized. That is going to change. But your generation, you have to get out there and you have to fight, because it's your scope of practice. Malnutrition is your scope of practice. So you have to own that, and you have to be on top of it, because the last thing you want is somebody from administration to come down and tell you, are you doing that? Yeah. And you're like, oh no. That's how you lose your scope of practice, right? That's when somebody goes over and automates things and takes off. So you're going to be on it, and then you have to be proactive and throw things up, so they know, oh, okay, you're on it. So that doesn't matter what profession you're at, you stay on top of your research, and you push it up. You push it up. That's the one thing it doesn't matter what your profession is, if you're PT or OT or whatever. On the outpatient side, like GI is really big. A lot of dietitians that work in clinics. One of my really good friends is the GI clinic dietitian over at Cedars. She's a rock star. Her name's Kelly Isaacson. I highly suggest you follow her on Twitter. If you're a dietitian, you should follow her. If you're can I get questions in a second, or do you want me to get questions now? Let me see. What do you got in here?
I have some questions that they filled out like a form. So then there's a bunch of questions here that I can.
Okay, I'll get those in a second. Okay. All right. So I'm gonna keep going, and then because I might hit your question, and then you know what I mean. So catch it at the end. Okay. So so dietitians are, so in other words, inpatient too. The inpatient dietitians are in the EMRs. They're let's see. They work with wound care, they work with the bedside nurses, they do the tube feedings, they do support on diet educations, they try to get the patients to eat more food, they're not just giving them oral supplements, because oral supplements don't work for everybody. There's big, like I said, big focus on malnutrition. They do something called a nutrition focused physical exam. They actually do a hands-on physical exam with patients to determine, fat loss. People use their nutrition differently when they're sick. Their bodies metabolize food differently when they're sick as opposed to when you're well. So when you're healthy and you're out there in the free and in the wild and in the community, and you're trying to lose weight, and you cut your calories down, your body has uses its keto. There's keto adaptation going on. People are using, you're using your free fatty acids, and it spares protein, right? But in the hospital, and this is really big for your nurses and your PTs, so I need you guys to know this, right? And your PAs too. When you're sick and you have inflammation, using protein, you use glucose first. Everybody uses glucose first, but after you go through your glucose stores, you go right to protein when you're sick. So when people are losing weight in the hospital, they're sick, they are not losing fat mass, they are losing lean body mass. That lean body mass protects them. Okay? Protects them from wounds, protects them. It keeps their body strong. This is where PT, I think, and dietitians are going to start partnering a little bit more in the near future, because it is, we need to be getting people before they come into the hospital, right? We need to be addressing malnutrition and nutrition risk and loss of lean body mass before they even come into the hospital. So that's going to be, I think, a future direction. I think, nurses, get your dietitians in early. You start seeing wounds, you start seeing people at risk, your patients are not eating. Please get get your dietitian in, make the referral, make sure your patient people just, make sure that you know that your patients aren't, they're not eating. It's a big deal. It seems like they'll be fine. They're just lose a little bit weight. They're overweight. People that are overweight, people that are obese can still be malnourished because they're losing their lean body mass and they're retaining the fat mass around them, but their organs are weaker because their lean body mass is disappearing. So we're going to end up starting to look at sarcopenic obesity and sarcopenia and diagnosing that through CT scans and ultrasounds. It's going to start getting to be, we're not looking at BMI really, because we're more looking at body composition, and that's where the field is headed. It's going to be really exciting. There's a lot of really cool things. There's a lot of great stuff to partner with. What else did I want to talk about? NICU RDs, a lot of NICU RDs, OBGYN. They don't really inpatient. They do a lot of work with the inpatient RDs because they generally a pretty healthy population. But on the outpatient side, you can have like gestational diabetes. Catch them in the community a little bit more. NICU RD is super important because they do like teeny tiny calculations. Like a lot of parenteral nutrition, which is IV nutrition, and also like lavage and how much breast milk the patients are being able to consume, and then they supplement with the amount with parenteral nutrition, and they have to watch head circumference to make sure that the patients are growing appropriately. So like this is all like it should have been some pretty cool stuff. Surgery is also a big thing for clinical. We're gonna do a lot with surgery in the next couple of years. I guess that's the big thing. I think I talked about a lot of stuff that I had written down here, Jonathan. Okay. Also speech pathologists, really close ties with dietitians. Speech pathologists are, they can be the difference between somebody going home to eat with their family or staying in the nursing home. Like if you think about it, right? If, you want everybody to transition from a tube feeding, if they can, to a diet, or, if they have, we want everybody to sit down and eat a Thanksgiving meal with their family, right? You want them to be able to enjoy that. When I worked at one of those smaller hospitals, the speech therapist and I, we would talk every morning, and we would come up with some plan about somebody that was about to transition, and we'd get them on a diet, and if they would successfully eat it and we pulled out the tube, we would go to their room and we would dance at the end of their bed. We'd be like, and we would just like turn it into this huge thing, and we made such a big deal out of it, and they would just beam and smile, and we made it like it was like an event, because it is an event, because oh my gosh, like even if it's puree, they're like eating this puree stuff and they're like, ah, and you're like, no, dude, you're only gonna have puree for 1 or 2, and then you're gonna bump up, and then you're gonna go home and you're gonna eat your favorite stuff. Like, this is great. And it was, so we turned it into this big thing. We made it really fun. And the one thing that I do need to tell you is there is nothing better. And this happens in like some of these long-term acute care places, is the next level of care. There's nothing more rewarding and nothing better when your patient comes back to the hospital to see you 6 months later, and they're like, oh, here, I'm doing good, I'm doing this, I'm doing that. I had one patient who was very, very, I can't give you any PHI or anything like that, but he was very ill. He had a really rough road, really tough trajectory. And then he came back a year later, and he came back with his brand new baby boy. And he walked in and he was like, and like, seriously, if we had not all done our job well, there would have been no baby boy. And so like, that is like, at the end of the day, like that's why we're in healthcare. Like that's for those like little moments. It's awesome. It's awesome. So, okay, questions.
So, okay, there's a few questions here. Let me see. I think you kind of covered that one. Okay, so there's somebody asked a question. Do you ever get compassion fatigue? You know, patients who are difficult to work with or do not like to follow their guidelines or what they're assigned to do. Is there, how do you remedy that, or what's like, how do you go about that?
Okay, so all right, so this is kind of how I look at it. The same people that are going to show up at Starbucks are going to show up in the hospital, right? And so the people who have the fussy order are going to show up in the hospital, and the people that like just roll with it going to show up at the hospital, and the people who it's not the exact temperature and who complain about everything are still going to show up in the hospital, right? So if you look at like, people are people, and you just kind of have to meet them where they live. So I look at, and so that's okay. You just kind of walk in and accept people for who they are, right? That's who they are. If they're difficult for you, you got them for 10 minutes, 15 minutes. They're difficult in a lot of other places in their life. And I'm sorry about that, but for you, you are there to just, I say that if you have somebody who's really, really difficult and they're not interested, you have to read the room, right? If they're not interested, then don't give them, and read off the same thing that everybody else is doing. Everything that's on the form. That's why I if I have my dietitians go up and they do an education, like I really pay attention to whether or not they know how to read the room. So if they don't, and you're just reading from your page, I'm gonna do that, right? You're trying to, if you put them on a continuum between 1 and 10, 10 being they're like, oh my gosh, I'm gonna do everything you say because this is amazing stuff. That's great. And if you get a 5, right, then you go, I'm gonna give you two things. I want to move you from a 5 to a 6. Like, you're not going to become a 10. You're not going to do everything I wanted you to do. You're never going to be a 10. You don't have to be a 10, but maybe you're a 4, and now you're going to be like, all right, I can do that. I can do that one thing. I can have a snack at night. Now they're a 5. And then they're like, that kind of worked. Okay, maybe I'll try this. And they'll move on their own, That's what the form is like. The education sheet is like for research, like for reference in the future. Like because they're not going to remember everything you say anyway, regardless, even if they are a 10, right? They're not going to remember everything you say anyway. So what you're trying to do is just to move, and it doesn't matter what you do, whether you're a nurse, your PT, whatever. Like some people are just your PT, then some people are like, I don't want to get up, I don't want to move, like it hurts to move, so I'm not gonna move. Like, why are you gonna make me walk? I don't want to walk. But maybe you can, all right, well, okay, so maybe I will walk to the car and back. Okay, that's a start, right? That's a start. So just move a little bitty. Jobs exist for nurses that have to do with nutrition. I don't want to be a dietitian, but I'm interested in the field of So the ASPEN is the American Society of Enteral and Parental Nutrition. So that is an interdisciplinary group. So it's an advanced practice group. So if you're interested in nutrition from you can become a health educator, but dietitians really should be doing like nutrition education, but nurses should be like vigilant and supportive on that, right? And the key with nurses is really being able to because to be able to see where the problem is and know when to bring in help, right? So that's good. But anyway, the ASPEN group is interdisciplinary. So it's doctors, nurses, pharmacists, and dietitians that get together, and it's mostly like a metabolism, they don't really talk about chicken at ASPEN conferences. It's like, metabolism and stuff. And so And you can become, see, I have this CNSC at the end of my name. Well, you can be a CNS, so you can be nurses can be a CNSC too. Doctors can be a CNSC too. Pharmacists can be a CNSC too. You just take an exam, and then you're just, at the top of your game when it comes to nutrition. As a nurse.
Let's see. We went to that one. Okay. So there's a question here. How can someone in nursing provide better nutrition care or encourage their patients to see a dietitian when they believe that they should see a dietitian?
So I think one of the things that nurses are supposed to record the amount of food that the patient ate at every meal. That goes into the medical record, and then the dietitian looks at that as they're pulling their stuff together to go and see the patient. So if you're accurate, then if your data is accurate, then the dietitian is going to go, oh, problem. Or they're going to go, okay, this person's actually kind of doing okay. Record the amount of supplements that the patient's drinking. That makes a big difference. The reason we don't want to put anybody on a tube feeding if you are recording the amount of supplements, the dietitian's going to go, they're like little accountants. They're okay, they're eating about 60% of their needs, and we can make a couple adjustments here, we can make an adjustment here, and we don't have to put them on a peg, right? We don't have to give them a tube feed. But if you don't put all the right stuff in, if you don't put accurate data in, then everybody's like guessing, right? And then people that don't need pegs get pegs, or feeding tubes. People who need feeding tubes don't get them. Things get delayed. People are catabolic. People start losing lean body mass. People, you know what I mean? Like, it just becomes this thing. So it's just about like good communication, good documentation, right? If you're running your enteral feedings in the ICU or anywhere at bedside, and be accurate about how many. If you had to turn it off because the patient had to go and do something, or they had high, whatever the reason, or they weren't tolerating something, and you had to turn off their feedings, document that, because the dietitians look at how much they got over the course of 24 hours and they calculate that out. Right? So if you don't put everything in, they're guessing. They're trying to figure it out. So that's really important. Encourage your patients to eat. If they're make sure if they need assistance with feeding, get them assistance with feeding. I can't tell you how many times people slap down a tray and the patients are like confused and are looking at it. Can't do it. Right? They're not like, and so now they're like super vulnerable, and and people, and then they were like, oh, they didn't eat, and he just took 2 bites and off, and they put their thing away. They put their tray in the pantry, and and they work on their meds. Well, if they don't eat well, blood sugars drop. Then you have to chase them with IV fluid, right? Then and it's this big thing. It's big chase. Oh, they're not eating. I'm just going to give them IV fluid. Well, yeah, but you give people too much IV fluid, and then then they start getting bowel edema because they start holding on to too much fluid, and then they throw everything up, and you got to clean that up. Right. So like it's, if they put on more than 2.5 kilograms in a day, right, and they're on IV fluids, they're holding on to all that water, and again, bowel edema, throw everything up. So we want them eating by mouth. We want them, and if they can't eat by mouth, they can't eat by mouth, then you give them, enteral feedings. We always use the gut. Always use the gut. Always use the gut unless you absolutely cannot use the gut. And then you do parental nutrition.
I'm actually really interested about this question too. So how do you foster better relationships with patients? I'm actually very curious about that too, because I know being like not just being monotone with like seeing somebody is like not the best way to go about it. I feel like many want to do, especially when one of my nutrition classes, they mentioned just trying to like make the interaction personal, or try to make it as intimate as you can. So, that's one of the things I want to, I'm also curious to like, how do you do something like that without, I guess, crossing the line per se, or going a little bit too much?
So you ask questions.
This
So,
question.
and that's for everybody. This is not just dietitians. You get in there and you ask questions. I'm a PT and I want to know, and I want somebody to walk 50 feet. You need to know, before they started talking to you, were they walking 10 feet or were they walking 40 feet? Right? Were they using an assist or were they walking independently? Right? You want to know all that. So can they get themselves out of the chair? Or are they stuck in the chair all the time? If you don't ask the question and you just regurgitate what you know, because you've done 100 of these educations and they need to be educated, right? No, wrong. Because then why are you here? We can just hand them a piece of paper. Right. So ask the question. So tell me. And from a dietitian perspective, Mr. Jones, tell me a little bit about what do you usually eat for breakfast in the morning? Okay. Okay, what about lunch? Okay, do you eat anything between? Okay, what about a nighttime snack? Do you have anything? Oh, okay. And then, okay, and then do you take any supplements? Then all of a sudden you find they're taking like 100 supplements. And you're like, right. Or they don't eat any protein, right? All of a sudden they're like, yeah, well, every morning I have, and you find out they're a vegetarian, but really they're a sugartarian, right? And all they really do is they just, they eat, they eat a Danish in the morning and my cup of coffee. And then at lunch, and they don't eat any protein. And then you're like, so they're literally, their blood sugars are going like this and they're constantly chasing that, right? So you have to teach them. So I guess, yeah, I'm rambling, but it's asking questions. Yeah.
All right. Another one here I have is, what are some misconceptions? I think you kind of answered this earlier, but what are some misconceptions that you hear about RDs? I'm actually very curious about that too, because every time I'm like, oh, I'm a dietitian, or not, I'm starting to become a dietitian or studying nutrition, they immediately think like, oh, he's gonna stop us, from eating, right? he's gonna make me go on a diet, So I guess I just want more, I guess, information towards that. Yeah, because I'm also curious too, because I sometimes like, I'm like, yeah, we are I guess we are, but at the same time we're not, because like you said, your malnutrition is a big thing right now. Well, it is a big thing. So it's kind of like back and forth, like, what do you do?
Well, because nutrition is tailored to the individual, right? We're tailoring it just like everybody's job. So whether you want to be a PA, it doesn't matter what you do. You want to be a nurse, right? The nurse anesthesiologist is not doing the same thing as the NICU nurse, is not doing the same thing as the rehab nurse, right? It's different. Everybody's different. That's why you are going to get a job. Like, that's why we hire all of everybody, no matter what you do, is because you listen to the patient, you go and you see that, and you are like, okay, well, this is what you need. This is what you need. Not everybody needs to go. For instance, here's a really good example. Plant-based diet, really, really important right now. Well, people are, there's a lot of people on the bandwagon for that, right? I'm answering your question. I don't want to lose track of the question, but they'll say like, everybody needs to eat a plant-based diet. Well, no, because people that to eat a plant-based diet is a lot of fiber. It's also fills people up. There's a lot of volume there. It's not all, it takes a little bit of nuance to make sure you're getting enough protein, especially if they need a lot of extra protein. And it's not okay. It's not the best decision for somebody who doesn't eat very much, right? Because you need to do something concentrated, right? You need to concentrate their calories and give them the most calories you can in protein in a itty bitty package, right? Somebody who eats a ton of food and is overweight, you're going to want to give them you might want to encourage them to be more plant focused, and and not everybody stays in that same lane all the time. So maybe the patient who's malnourished, even if they're obese, even if people who are obese can still not eat enough because they're sick, right? And they're running a lean body mass. So you may start them out in something that's like high calorie, high protein, and your doctor's going to go, they're overweight. They don't really need all that calorie. Yes, they do. And you're going to have to take that on, right? Because people have a misconceived notion of what we're doing, right? It's different. It's different. And then that patient, when they go out in the community and they're feeling better and they're off and they're in their, then you want to put them on a plant-based diet and plant fortified, because now at this point they're ready to go. They're fine. They're good to go. And then you want to move them over there. So it's, did I answer the question, or I just ramble? Because I'm kind of rambling.
No, you answered it perfectly.
Okay. Okay.
Let's see. There are some questions in the chat. Chantel asked, what are the stages to get your profession? How do I have to become, and do I have to become a dietitian first, or would I have to be majoring in nutrition? And how would we go about getting our foot to the door, working for someone or under someone?
So, okay, let me look at that question. Okay. Okay. So if you want to be a dietitian, okay, there's a bunch of prerequisites. Actually, it sounds like a super easy major. It's actually not. It's there's a lot of chemistry, biochemistry, nutritional biochemistry. There's it's metabolism. Nutrition is not about, it used to be about like, it used to be like what people used to think it was, food police kind of stuff. It's all about metabolism now. So you're going to have some hard classes, right? But you can take those, some of those prerequisites at your community college and get some of those out of the way. Anatomy, physiology, you gotta go you gotta do all the chems, you gotta do OChem, you gotta do biochem, you gotta do vitamins and minerals. That wasn't an easy class. And then you go through and you take, and then you have to get a master's degree now, and the reason why, it used to be just a bachelor's degree, but now you have to get a master's degree. But honestly, the reason why is because the profession is getting more sophisticated. And if you, you need to, it's maybe 10 years ago, it was okay to just have a bachelor's degree, but it's getting more and more, you just need more education. You just need to push it. So you do that, and then you can, you take the prerequisites, see if you like it. If you like it, great. Then you apply for the program. Then you have to take an internship, and then you have to take the RD exam. The RD exam, you do I did a 9-month internship. I think now they have this whole nother way of doing it. Jonathan can explain that a little bit more than I can. There's a whole nother didactic program that I didn't go through. But anyway, so, and then you have to, it's so like a certain portions clinical, certain portions community, certain persons food service, and then the RD exam covers the whole thing. So everybody who goes to be a dietitian has to know how to do all of these things. And it's a lot, because there's sports nutrition and clinical nutrition, it's really a lot. And the thing that takes everybody down is the food service stuff, because they're like, oh my God, what's the % yield on the chicken? Right. And then if you never use it again, right, or you're not interested in it, you're just like, but you got to pass that part. And it's, so anyway, so you go there, you take the RD exam, and then you apply for a job. And I don't know how they're doing the master's degree thing right now, to be honest. I don't know if you I think I don't really know if they do the master's degree at the same time they're going to do the internship. I don't know, Jonathan, you might be able to answer that better than me.
From what I've heard, it's that they're doing what they want to do, like a joint thing. So you could, when you had to get your master's in, like on the second year of getting your master's, you can also do an internship at the same time. But you can also just finish your master's first and then do the internship afterwards.
Okay.
But I think it depends on the schools too. Because I believe I think CSUN is doing something similar to that. I'm not too sure, but
Okay.
that's what I've heard so far.
It's in transition right now, so it's a little different than I did it because I'm old. Yeah. What else is there? Let's see. What other questions you got? Did I get everything? Did I get that question? Did I answer that? But the foot in the door to working under somebody, and then you just you can and you can also volunteer. I've had a bunch of volunteers come through. They kind of follow me around, follow dietitians around. But be prepared that if you do that, you're gonna get a lot of stuff that may not. The nice thing about volunteering is that you can kind of the thing that helps with the food service side, even if you're not interested in it, you have to pass it for the RD exam. And so to be able to be in like a hospital kitchen and see how the flow works and why this is important and why this isn't important, and just be able to visualize it will help you get through the exam a little bit easier. Because the clinical stuff, I mean, you can follow the dietitians up and they can do an NFPE, but you can watch them do their nutrition focused physical exams and all that stuff. They can't really do anything. The clinical stuff, we saved that a lot for the interns. Okay, that's it. Sorry, rambling.
All right. Let's see. So I think that's about the end of our meeting, right? I think it's 12:15.
Okay.
I know there was more questions in the chat. I'll try to screenshot them. Maybe you can answer them at another day, maybe, and then I just let them know. But yeah, this is 12:15. I don't know, Wendy wants
Yeah,
to.
go. You gotta go.
It's still completely fine if you continue the meeting, but I do want to say this because I see some members leave it right now. But I know there was a question regarding the certificates. Those will be sent out towards the end of the meeting, or towards the end of the semester. But if you attended 4 meetings and you've done the attendance form for each of those meetings, you will receive a membership certificate. And if you've done 6, you'll receive an outstanding membership. So just keep an eye out towards the end of semester and into your student emails. Those will be sent out to you. But yeah, it's okay if you want to go overtime.
I don't know, Mary, if you have time or do you gotta go?
I have just a few more minutes, but I have to run around and do some stuff. But I just want to conclude, I see the oncology question. I mean, it's just specialized, right? You just be good at what if you love oncology, you got to learn the meds. You got to partner with your nurses, right? You got to know how this chemotherapy drug is going to affect this patient and how radiation on this particular area is going to affect your patient. How are you going to help them, right? How are you going to help them? How are you going to close this gap for them?
Yeah.
Right. So there's screening tools, but you gotta get in there and ask questions. You just got, what is their problem? Because this person's problem is not that person's problem. So yeah. So yeah, it looks like you have a professor here who's willing to mentor you guys if you have any questions. So that's fantastic. What else? I don't know. I can't. Practices, majoring, nursing. You know what? You could be a nurse and an RD. Why not? You could be a doctor and an RD. There's a couple RDs that are doctors. We have one in our department who's a PA and a dietitian. She went to do. Who knows? You can do anything you want. You can do anything you want. What's a CPD? Oh, I don't know. I don't know the answer to that question. CPD or DPD. I asked Dr. Ortega about that. I'm out on that one. No.
Awesome. I think that covers all of our questions. Thank you so much, Mary. I appreciate you coming. I know it takes a lot to come over here and talk to us students, but yes.
You guys are the future, though. You guys are the future, and really, the only other thing I would say is get out of your silos. It's really, really, really easy to stay in your silo because you're so busy learning. But the way that you're going to make a difference in your patients' lives is you have to get out of the silo of your profession, and you have to get to know what other people do and how you can interact with them and how you can make their job easier. How can I make your job in your head? How can I make their job easier? And when
Okay.
you say that in your head, how can I make the RT's job easier? Maybe not overfeeding them. Maybe don't overfeed those patients when they're trying to get them off getting them off the vent, right? So, how can I make other people's jobs easier? And they'll tell you. Okay.
Awesome. I appreciate it so much, Mary. Thank you.
All right. Take care.
Take care, Mary.
Thank you.